Hello everyone, I am Dr. Sandeep Sharma, your pediatric faculty for NEET PG and FMGE at DocTutorials. So here we are going to have a FMGE pattern recall for the July 30 paper related to pediatrics questions. So this discussion is based upon the recall by the students, and if the options change, statement stem change, obviously the answer will also change. So it is purely based upon what most of you have shared with us, and many questions are integrated or overlapping. So one question can be considered as a part of pediatrics also, it can be considered as a part of other subject also. The aim of this discussion is to give you an idea how the questions were asked. For those who have given the exam, they can have an idea, fair idea where they stand. And for those who will be targeting the December exam or the subsequent FMG exams, you will know that the topics are important. And understanding the way questions are framed are obviously more important. So any resemblance to actual question is purely coincidental. This is a legal disclaimer that we are supposed to share. So let us start with the discussion. Question number 1. A neonate presented with complaints of bilious vomiting. So the word here is bilious vomiting. Bilious vomiting means the obstruction is not in the stomach, it is beyond the stomach. It is duodenal, jejunal, ileal, likely those kind of obstruction. There is minimal abdominal distension, okay? And the X-ray abdomen was done and it is shown below. What is the likely diagnosis? As you can see, there are two bubbles seen here. One is the stomach bubble and one is the proximal duodenal bubble. So this is the so-called double bubble appearance. So it's a very frequently discussed question in most of the discussions that we had online as well as offline. I have discussed that double bubble appearance, most common cause in a newborn is always duodenal atresia. Atresia means absence of lumen formation. Answer here is duodenal atresia. Because remember, single bubble appearance is a feature of congenital pyloric stenosis. But in that condition, you will not have a bilious vomiting, that will have a non-bilious vomiting, right? So B option is unlikely. Hirschsprung disease does not present like that. And diaphragmatic hernia will have herniation of intestines into the left part of thoracic cavity. So the only logical answer here is duodenal atresia. So that is the answer. Remember that in duodenal atresia, the clinical hallmark, remember the clinical hallmark of duodenal atresia is always bilious vomiting on day 1 of life. Bilious vomiting on day 1 of life, but there will be no abdominal distension. And this is the typical presentation how duodenal atresia presents with. Duodenal atresia is one of the most common varieties of intestinal atresia, particularly common in Down syndrome. So additional thing about duodenal atresia that you can remember, that duodenal atresia is very common in Down syndrome, that is trisomy 21. So this is an additional point that you can remember for future exam. Let's have a look at something very important. These are the 3 images which can be asked to you in the exam. So you need to be able to identify those. If you are preparing for December exam or subsequent exams, very important. So what is this first image showing? This first image will be the single bubble which is appearing. So this is the so-called single bubble appearance. Single bubble appearance is typically seen in patients with CHPS, also called as IHPS. CHPS is congenital hypertrophic pyloric stenosis, also called as idiopathic hypertrophic pyloric stenosis. These patients will always have a non-bilious vomiting. So MCQ will say non-bilious vomiting and single bubble appearance will be shown. So that will be the likely answer. This is the so-called double bubble appearance. So double bubble appearance, as I just told you, it is seen in patients with duodenal atresia. And duodenal atresia patients will have a bilious vomiting. And third variety, as you can see, the so-called triple bubble appearance. So 3 bubbles are seen. So triple bubble appearance usually seen in patients with jejunal atresia. It has rarely been described in a jejuno-ileal type of atresia where both jejunal and ileal atresia coexist. But for all practical purpose, jejunal atresia where 3 bubbles are seen, triple bubble appearance. And these patients will also have a bilious vomiting. So this image and the description, the points I told you, please mark it. Very important, high likelihood of getting repeated in one way or the other. Let's move further. Talk about question number 2. A child presented with complaints of malnutrition and severe dehydration. What shall be the IV fluid of choice in this child? This is again something that has been commonly discussed. Whenever there is severe dehydration, you need to use IV fluids. So you understand that whenever patient is having severe dehydration, any child with severe dehydration, the child is unable to drink any fluid. So we always use intravenous fluids in the patient, right? Now, which IV fluid to use, that is important. In most of these scenarios, mostly, if nothing else is mentioned, the favored fluid for these children is ringer lactate followed by normal saline, right? However, if the question says severe malnutrition or a kwashiorkor or marasmic child who develops malnutrition and you need to use IV fluids, these children are also having chances of hypoglycemia. Hypoglycemia is a complication, and so a specialized fluid in them is used, what you call as ringer lactate in 5% dextrose. That is the best fluid. If that is not possible, then you will go for ringer lactate and followed by normal saline. Remember that if you are using ringer saline in them, there is a chances of hypoglycemia. And so this is the fluid that will be preferred in these individuals. So answer to this question is ringer lactate in 5% dextrose. Question number 3. A child presented to the clinic with complaints of recurrent infection. So bar infection हो रहा है. There is also a history of faulty feeding in the child. On evaluation, height for age was much less than expected. We all know that this is a patient who's having a long-term problem. So if there is a long-term chronic disease or chronic illness or faulty feeding, height will not grow. If height for age is below -2 standard deviation, the term for that is stunting. And that is one of the option here. So stunting is the answer. It is an indirect repeat converted into a clinical question. This question has been asked 2 times. And if you look at the previous recall session, which I had done on YouTube channel of DocTutorials, I have discussed this question. So this is the discussion which I had. It is also there on the DocTutorials app. If you remember, I had discussed that these 3 nutritional indices are very important, and one of them in direct or indirect way will surely be asked. This is a snapshot of what I had discussed at that time. I'm not claiming that whatever I discussed came in the exam. Nothing like that. What I am trying to say is that in FMG exam, if a topic is important, it has a high likelihood of getting repeated. So if you are an FMG examiner, focus on previous year questions plus understanding them and making concepts in them. Simple one-liner are not going to work anymore. Build concepts so that the question changes, you still are in a position to mark it correctly. So answer to this question is C, that is stunting. What is stunting? So stunting is said to be there when height for age of the patient is less than -2 standard deviation of the expected. What is wasting? When weight for height in the patient is below -2 standard deviation. And what is kwashiorkor? Kwashiorkor is a type of severe undernutrition. It is a type of severe malnutrition where there is edema along with weight for height below -3 standard deviation, what we call as severe wasting. Sometimes MUSC below 11.5 is also severe malnutrition, but kwashiorkor will always have edema. So kwashiorkor will be edematous. SAM, edematous severe acute malnutrition. And what is underweight child? The definition for this is weight for age below 80% of expected. So these are the 4 definitions. You remember them one way or the other, it will be repeated again. Question number 4, again very frequently asked, a repeat question. What is the cutoff to define severe malnutrition in mid-arm circumference? It is less than 11.5. Remember, when you are checking for mid-upper arm circumference, also called as mid-arm circumference, the normal value in the patient is always 15 to 17 centimeter. If MUAC becomes less than 12.5 centimeter, that is called as moderate undernutrition, also called as moderate PEM. And if it is less than 11.5 centimeter, that is called as severe PEM, severe protein energy malnutrition. Extra edge point. What is this classification known as? Extra edge point. Please write it down. It is known as Arnold classification. Arnold classification. The next time they might make a MCQ out of it. Arnold classification uses which parameter to assess malnutrition? Simple thing, mid-arm circumference. And mid-arm circumference cutoffs you already know. You basically, if the examiner repeats a question, he either changes the options or he converts a one-liner into a case scenario into a one-liner, or he will move one step ahead and ask slight more detail of that particular topic. So any topic more than once or twice asked in the past 4-5 year papers, read it thoroughly and build the concepts what this is trying to say. So mid-arm circumferences between acromion process and olecranon process, you check it. Between the age group of 6 months to 5 years, it remains constant. If it changes, if it is below a certain threshold, it indicates malnutrition. Next, question number 5. A child diagnosed with celiac disease should avoid all of the following foods except. So this question is asking celiac disease, wheat allergy, gluten sensitive enteropathy. So wheat based things cannot be used. So wheat cannot be the answer. They are asking safe food kya hai? What is the safe food? This question is asking you the safe food which is to be given. Barley cannot be given, oats cannot be given, right? Rye cannot be given. Only two cereals are found to be safe. Safe foods in celiac disease are rice and maize. Now, maize is not in the option. Rice poha is mentioned. Some people said sir, rice pulao was the option. Some said simple rice was there. Some said only poha was there. Rice poha is the correct answer. Rice is the safest cereal. Now, many people got confused about suji or semolina. What about suji or semolina? Remember, suji or semolina, also called as rava in South India. Rava dosa, you all know. Suji, semolina, or rava, they are all varieties of wheat. They are a variety of wheat. Just like you make aate ka halwa, similarly you make suji ka halwa. Both of them have very similar consistency and they both are types of wheat, and so it is unsafe in a celiac disease patient. So answer to this question is rice or poha, right? Next question. What is the dose of vitamin A given in a child aged 1 to 8 years? Now in a 1 to 8 year, till 8 years of age you don't need to give it. The doses of vitamin A is very clear. We have discussed it already multiple times. Less than 6 months of age, the dose is 50,000 international units. 6 months to 12 months, the dose is 1 lakh international unit. And above 12 months, the dose is 2 lakh international units. And these doses are the age-wise doses that are recommended. Now, in a child aged 1 to 8 year, means above 12 months, the dose will always be 2 lakh international unit, and you will be giving 2 lakh international unit according to the National Health Program, and NPCB, the National Program Control for Blindness, also recommends that 2 lakh international unit every 6 months should be given till 5 years of age, and so D option is the correct answer. Moving to question number 7. In which trimester is the quadruple test done for antenatal screening of Down syndrome? Antenatal screening of Down syndrome, very, very important. Let us summarize here. Antenatal screening, I am doing a summary here. All those who will be appearing in future, please store this video, save this video for later review as well. So antenatal screening of Down syndrome, that is trisomy 21. So first we do the testing in the first trimester. So what is the test that we do in first trimester? In first trimester, we will be doing a test known as combined test. What is combined test? Combined test uses 3 parameters. We first do ultrasonography or ultrasound in the child, and we look at the thickness of neck fold at the back of the neck, right? Not in me, obviously, in a fetus. So ultrasound showing increased nuchal translucency. Increased nuchal translucency. The word nuchal always means a neck or back of the neck. There will be increased thickness of the neck fold. There is a edematous layer which will be visible on ultrasound. That thickness will be increased. So ultrasound showing increased nuchal translucency is one feature suggestive of Down syndrome. Second, we check for beta HCG levels, and beta HCG levels will be increased in a patient of Down syndrome. And third is a substance known as PAP-A levels, pregnancy associated plasma protein. PAP-A is pregnancy associated plasma protein type A. Its levels are found to be reduced. So this is the combined test picture suggestive of Down syndrome. Then we do the second trimester screening. In second trimester, what do? We do a test known as triple test. What does triple test check for? It checks for 3 things. Maternal serum alpha fetoprotein, which will be found to be reduced. We will check for beta HCG, which will be found to be increased. And you will check for unconjugated estriol, which will be found to be reduced. And then we have the quadruple test. What is quadruple test? Quadruple test is the same as triple test. So it is the same as triple test, but you test for additional thing known as inhibin A. And inhibin A in Down syndrome patients is found to be elevated. And finally, we have the test known as integrated test. So many tests, but they are very easy to remember. Integrated test means first trimester combined test and second trimester quadruple test. The only catch here is when you do an integrated test, beta HCG is being tested 2 times. First trimester also, second trimester also. So, and this is actually not needed. So in vast majority of patients, what we try to do is, if we are doing integrated test, we should do beta HCG only once. So either in first trimester or in second trimester, we will be omitting it out. Right? There are different protocols are there based upon the types of screenings that we do. But beta HCG will be done only once. So remember, combined test is done in first trimester. Triple test and quadruple test are done in second trimester. If they particularly ask which parameter can be checked in any of the trimester, first or second, it is beta HCG, right? So this is the antenatal screening. And in which trimester should it be done? Now the answer is very clear. Quadruple test should be done in the second trimester. It is not first and second trimester. And third trimester, obviously, we are not going to do any screening test or these markers. Let's move further. Question number 8. Look at the image and tell the associated genetic anomaly. So similar image was asked in the exam. There where a large simian crease was present. What is this known as? Single transverse palmar crease. Single transverse palmar crease, also known as simian crease in the patient. And simian crease is typically associated with Down syndrome. And what is the genotype of Down syndrome? 47XY plus 21. So additional 21 chromosome. Easy one. So Down syndrome, 3 features to remember. What are the features in the hands and feet that you need to remember? First will be simian crease, which will look like something like this. Suppose they repeat the question and show some other image. Look at the hand of the Down syndrome child. Many times the 5th finger will be shortened and curved inwards. This is called as clinodactyly. Clinodactyly. So the short finger is curved inwards like this. It is shortened and curved inwards like this. Right? As you can see in the picture. And third, if you look at their first and second toe, there is increased gap between the first and second toe. That is what we call as sandal gap. All the 3 are important spotters, can be repeat questions in the upcoming exams. Then a child with the following birth defect was delivered. What is the likely diagnosis? Actual image in the paper was very similar, but it was a colorful image. So during recall, I could not get the colored image, so I'm using the black and white one. Whether black and white or colored, look at what you can find in this. There is absence of the forebrain, absence of the cortex, absence of the brain. So this child is having anencephaly, and this child is also having a large cleft, so that most of the spinal cord is visible to the outside. That condition is called as craniorhynchisis. One of the options mentioned in the question was anencephaly and craniorhynchisis, and that is the answer. So this is a child having a severe neural tube defect. Craniorhynchisis. Rhynchisis word means splitting and exposure, right? Cranio means it's the upper part of the, usually the head is also involves the upper part of spinal cord and extends variably up to the thoracic or lumbar spine. So what will happen in these children is there will be absent brain, anencephaly will be there, and if you starting from the back of the head, you will find there will be entire splitting of the vertebral column with the exposure to the outside. It is a condition not compatible with life. You can check it in utero by antenatal ultrasound. You can do the markers like alpha fetoprotein and acetylcholinesterase, which will be elevated in these patients, right? So these are the 9. Answer is this. Now, severe neural tube defects, 3 important neural tube defects you should remember. This is the child where the brain is absent, right? So this is anencephaly. This is the variety which we just discussed, anencephaly with craniorhynchisis. And this is the variety where the posterior part of the occiput is fusing with the shortened upper 3 or 4 vertebra. This condition is known as iniencephaly. Iniencephaly will be a child with a so-called star-gazing appearance. Isn't it looking like the head of the child is stuck like this? Like this. This is what you call as star-gazing appearance. All the three are severe neural tube defects. Most of them are not compatible with life. So stargazing appearance in anencephaly. So you can get question on this. This image has been asked. This image has been asked. This image not asked so far. Maybe it would be a fresh question for you in the future. Question number 10. Which of the following hormone is involved in galactokinesis during breastfeeding in a child? Now there are two parts, milk production and secretion. We have galactopoiesis, that is production. Galactopoiesis or milk production is controlled by a hormone known as prolactin. On the other hand, galactokinesis is caused by active movement of the milk outside the breast through the nipple, that is milk ejection, which is produced by oxytocin. This is a past question. Earlier they had asked, some years back they had asked the question, milk ejection is performed by which hormone? Answer was oxytocin. This time they said galactokinesis is produced by what? So alternative name, technical terms should be clear in your mind, oxytocin. That is what milk ejection is also known as galactokinesis. It's a very small concept. But if you know the concept, it's an easy question. If you don't know, then it becomes really difficult for you. So this is the so-called, as I said, the cycle which is happening. Whenever a child suckles on the mother's milk, a mother's breast, there will be positive feedback going to the brain. There will be secretion of anterior pituitary and posterior pituitary. Anterior pituitary will produce prolactin, which will cause milk production, and there will be oxytocin produced from posterior pituitary, which will cause milk ejection. Which of the following micronutrient deficiency is associated with poor wound healing, alopecia, diarrhea, and dermatitis, that is rash? As soon as some people read poor wound healing, they started thinking of vitamin C. No. Wound healing with bleeding gums is vitamin C. Poor wound healing with alopecia, diarrhea, and dermatitis is indicating loss of epithelial integrity, typically produced in patients with zinc deficiency. Remember that zinc deficiency can have these manifestations. There are two types of zinc deficiencies. One is the dietary zinc deficiency, which is considered to be relatively milder. Second is called as the genetic zinc deficiency. The typical name for genetic zinc deficiency is acrodermatitis enteropathica. These children will have a severe dermatitis, rash, perianal, perioral, cheeks, and hands and feet. And they will also be having alopecia, poor wound healing, recurrent infections, candida infections, etc. It is an autosomal recessive condition and usually requires lifelong megadoses of zinc. The gene involved here is SLC39A4 gene, which is a past MCQ point as well. So question 11, the answer is B. If they say maize eater developing photosensitive rash, answer will be pellagra niacin deficiency. If they say bleeding gums, milk diet, poor wound healing, then the answer will be vitamin C. And magnesium deficiencies are not that common, and they are usually not described. They do not have a identifiable clinical picture compared to the other micronutrient deficiencies. Question number 12. A neonate delivered via normal vaginal delivery is started on mother's feed. Okay. After feeding, he developed vomiting, hypoglycemia, cataract developed, oil drop cataract, big clue. Hepatomegaly and mild icterus, urine was positive for reducing substance, but no glucose was found. This is all fitting into our diagnosis of galactosemia. So the question arises, what variety of galactosemia? Galactosemia, three enzymes are involved. We have galactose 1-phosphate uridyl transferase, galactokinase, and epimerase. Out of them, galactose 1-phosphate uridyl transferase is the most likely cause. This is the most common type of enzyme deficiency in galactosemia. This is also the most severe form, and this enzyme deficiency produces the so-called classic galactosemia. Classic galactosemia. In patients with galactokinase deficiency, hepatomegaly, jaundice, and acute presentation will be rare. Galactokinase is a milder illness, and there is cataract which is common, but other features are usually missing, and so galactokinase is not the answer. Other remaining ones are definitely not the answer. Answer here is galactose 1-phosphate uridyl transferase. These patients, cause of death is either hepatic failure or severe hypoglycemia or sepsis due to E. coli. So remember, galactosemia, E. coli sepsis rate is very high. This is again a past MCQ point related to FMG exam. Treatment: stop all milk, specialized milks, formula milks, which do not have galactose or lactose in them, that should be given. Question number 13. 13-year-old girl presented with complaints of increased bleeding after dental extraction. Local measures failed. She was evaluated. Prothrombin time was normal. Which of the following is correct about the diagnosis in this patient? There are two ways you can reach this question. Either you can look at the history and reach the diagnosis, or you can rule out other options. How you will rule out other options? Factor A deficiency produces hemophilia A. Factor B deficiency produces hemophilia B. Both hemophilia A and B are X-linked recessive condition, and so they will be seen only in males. Females are carriers, they do not manifest the disease. So B is not the answer, C is not the answer, right? Vitamin K deficiency can cause clotting factor deficiencies, but this will cause elevation in PT, elevation in APTT also, and elevation in prothrombin time is the early sign because there is factor 7 depletion which is commonly seen in these patients, right? Here PT is normal, so D option is ruled out. What are we left with? Von Willebrand disease. Remember, von Willebrand disease can occur in males or females. These patients present with increased chances of, if it is a girl, menstrual bleed. They also have increased chances of epistaxis, that is bleeding from the nose, and they sometimes have gum bleeds as well. Also, von Willebrand factor is a carrier of factor 8. So in these patients, prothrombin time will be normal, but APTT will be found to be slightly prolonged. Rare patients, it can be normal as well. So slightly prolonged levels will be seen. So this patient is sitting into von Willebrand disease. Approach to bleeding child is very important. I have discussed in my online lectures. I have discussed in my offline classes. Those sitting for December exam, approach to bleeding child, 100% will be asked in one way or the other, in one exam or the other. I'm not saying in FMG exam alone. If you have 3 exams in a year, FMG, NEET, PG, INI, CT, in one of these exams, you will always find it. It's a big topic. Medicine questions can also be asked on this. Remember, if there is a person, child or adult, who is bleeding with trivial trauma, minimal trauma, or spontaneous bleeding is happening, rule out micronutrient deficiencies, rule out local factors. In case it is a petechiae purpurechymosis, likely to be platelet disorder. In case there is a deep bleeding, muscle hematoma, joint bleeding, likely to be hemophilia. In case both prothrombin time and APTT are prolonged, think of liver disease and vitamin K deficiency. And in case this kind of picture is seen where female child is there, menstrual bleed is there, prothrombin time is normal, APTT is slightly elevated, which very cleverly they did not mention, the answer will be von Willebrand disease. Understood? Remember these points. I have discussed in details. This is about question number 13. Very standard, good quality question. Question number 14. Questions are becoming more and more clinical, as you can see. Child brought with 2 weeks history of not feeding well, irritability was present, he was evaluated, neck rigidity, so likely meningitis. His sister was already taking treatment for TB, so contact with tuberculosis. CSF will show what? So they are asking about the CSF picture in tubercular meningitis. If you remember, I have discussed it in my previous recalls video, which is there on YouTube. And there I had said, मैंने बोला था कि लिख लो, snapshot ले लो, पक्का आएगा किसी ना किसी फॉर्म में आने वाले एग्जाम्स के अंदर. And this is what it happened this time also. So in English translation, I had already said that take a snapshot, remember this, some way it will be asked. I did not know it will be asked just like that. You may or may not get it next time, but you understand, questions are clinical, topics are same, but they are asking more details. So what is the tubercular picture? I need not make the entire table now. You can see that these patients are having lymphocytosis. There is low sugar in the patient and high protein. Tubercular meningitis is characterized by specifically high protein, and these patients also have pellicle or cobweb coagulum formation. If you keep the CSF for some time. So CSF findings we have already discussed. I'll just summarize again. Normal CSF, the cells are 0 to 5. They are mostly lymphocytes. CSF protein is 20 to 40 milligram per deciliter. CSF glucose is 50 to 70 milligram per deciliter. Normal CSF is clear. Normal CSF is sterile. Acute pyogenic meningitis, cell count is significantly elevated, but it is neutrophils which are seen. Exact values I have discussed in detailed videos. Tubercular meningitis, cell count is increased, less compared to pyogenic, but these are mostly lymphocytes. And aseptic meningitis, mild elevation, the cells are lymphocytes. CSF protein is elevated in pyogenic, significantly elevated in tubercular, usually in the range of 100 to 1000. Whereas aseptic meningitis, it is mildly elevated. CSF glucose is reduced here, less than 40. Here also it is reduced. Normal CSF glucose is the hallmark of aseptic meningitis. Pyogenic meningitis, the CSF may be clear or turbid. Tubercular will show pellicle formation. Aseptic meningitis, the culture is always sterile. Detailed table is there in the discussion. This is a quick review or for future exam. Question number 15. Amount of feeder fluid to be given in a term baby in the first 24 hours of life. Normally, a term baby should be started on breastfeed and it should be breastfeed on demand. We do not calculate how much feed the child is taking. Usually every 2 hourly, we allow breastfeed to the child. But if the child is not on mother's milk, you will need to give IV fluids or you will need to calculate the milk to be given, formula milk, and then give to the child. So the question arises, how will you calculate that? Remember that on day 1 of life, if mother's milk is not being given, term baby will be needing 60 ml per kg body weight per day, that is in 24 hours. And preterm baby will be needing, because he has to show catch-up growth, 80 ml per kg body weight per day. So suppose 3 kg child, how much fluid will you give? 60 multiplied by 3, 180 ml in 24 hours. So you will divide it in equal parts and give every 2 hourly if it is a oral feed or a tube feed, and you will set a rate if it is a IV fluid. So term and preterm baby. And once you start on day 1, every day you increase the feed by 10 to 15 ml per kg per day. So that by day 7, the child reaches about 150 ml per kg per day. In case of preterm baby, it can go beyond that as well. But in no circumstance we will exceed the 170-180 wala value. Remember, this is the upper limit. Iske upar nahi jana hai. You will not go beyond this. You cannot keep on increasing indefinitely. Then there are specific formulas for that. So this is the gradual hiking of feeds which is done in the first week of life. Also remember, extra edge point. In the first 48 hours of life, if you have to use a IV fluid, तो कौन सा IV fluid you will be using? You will be using 5% dextrose or 10% dextrose. So sodium containing fluid will not be used in the first 48 hours because renal handling of sodium is not mature in the first 48 hours. After 48 hours, you can use IV fluids in the form of isolite P, which has sodium in it, or you can use N/2 half normal saline in 5% dextrose. So what fluids to use? This is also important. I'm putting a star here, right? So answer here is term baby 60 ml per kg. If it was preterm, answer would have been 80 ml per kg. A baby was born to HIV positive mother who is not on antiretroviral therapy. What should be the initial prophylaxis to start in the baby? Now options are not completely recalled and students said nevirapine, zidovudin, etc. were mentioned. So one option also had nevirapine plus zidovudin and duration was 6 or 12 weeks. So irrespective of whatever was mentioned, this question is taken from the latest guidelines of NACO 2021 plus WHO update. And what are the latest guidelines which they say? Look at the guidelines. Guidelines say that whenever a baby is born to HIV positive mother, baby is called as HIV exposed infant. We categorize the baby into 2 parts. Either it is a low risk or it is a high risk infant. So what is a low risk infant? In case infant is born to a mother who is on antiretroviral therapy. So mother is taking the antiretroviral agent, and at 32 week, when you checked for the viral load, mother में कितना viral load है, क्या वो ART effective है, you found that there were less than 1000 copies per ml anytime after 32 weeks of pregnancy up to delivery. तो इनमें chances of transmission low होता है. On the other hand, what is a high risk infant? Infants born to HIV positive mother not on ART, or maternal viral load हुआ ही नहीं, or maternal viral load was done but it was not suppressed, or mother has recently been diagnosed within 6 weeks of delivery, right? So these will be called as high risk infant. In case of low risk infant, according to guidelines, what do we give? We give oral nevirapine Zidovudin नहीं prefer करते आजकल. Oral nevirapine will be given for 6 weeks. On the other hand, if it is a high risk infant, you will use a combination. You will use nevirapine along with zidovudin, which will be given for 6 weeks. Remember, there is a catch. If the child is on exclusive breastfeeding, which is what is recommended, the duration can be increased up to 12 weeks, right? So as per students, there was only one option which had nevirapine plus zidovudin to be given, and that would have been the most correct answer. Because look at the question. HIV mother is not on antiretroviral therapy, and what is this baby? High risk infant. Most of the other recalls which have been done, even when I was doing the initial recall, I did not have this much of information. And so even immediately some student asked me immediately after the exam, sir, there was a question on HIV positive mother, what drug to give? So I gave the answer, you give nevirapine for 6 weeks. That is the default statement, right? But the information which is now available, they are asking in details, and they are asking that mother is not on HIV antiretroviral therapy, then combination therapy needs to be given, right? Tough question. I agree, tough question. But again, something which has been discussed. If you see on my YouTube channel, I've already discussed management of HIV positive infants. That video is already there. I've been discussing in my classes also, and not just me. I'll be disclaimer. Other excellent faculties have also discussed that. But it is something which we do not expect in such details to be asked in FMG exam. Tough question. You got it right. Excellent. You didn't go through in this particular question well. It's okay. You have other questions also. Question number 17. Now, this is an easy one. Delayed wound healing after minor surgery is due to deficiency of nothing else mentioned. Which vitamin is responsible for delayed wound healing? Vitamin C. Why? Because of poor collagen formation. Defective collagen formation. Collagen is unstable. Vitamin C is required in the cross-linking of collagen fibers by hydroxylation of proline and lysine residues. And that is why poor wound healing, defective collagen formation, vitamin C. Remember this. Question number 18. A male was found to be infertile, had a genotype of 47XXY. This is Klinefelter, obviously. Which of the following is incorrect? Hyalinization of seminiferous tubule is a true statement. Gynecomastia common is a true statement. Low testosterone level is a true statement because the gonads are not producing enough testosterone. Because the gonads are not producing testosterone, feedback inhibition will be lost. And so FSH and LH levels will be high. So this is a false statement, right? So low FSH nahi hota. These patients have hypogonadism with raised FSH and LH levels in patients of Klinefelter syndrome, right? So a bit of it's an overlap question. There is a bit of physiology here, bit of pediatrics here, bit of genetics here, all of them combined, and bit of OBG also, because they are talking about hormones. So low FSH levels are not seen, high FSH levels are seen because the feedback inhibition of testosterone is gone. So this is the typical person with Klinefelter syndrome. We have discussed it already. Question number 19. Etiology of post-streptococcal glomerulonephritis and rheumatic heart disease. Easy one-liner, group A beta hemolytic streptococcus, right? The mechanism is different. PSGN is caused by immune complex phenomena. RHD or rheumatic fever is caused by molecular mimicry. Easy one. Question number 20. There was one question on the most common cause of neonatal meningitis. Now the options were not recalled, but remember that the most common causes of neonatal meningitis, age-wise, you have to remember, whatever the options were given, in case of newborns, it is mostly caused by group B streptococcus, followed by E. coli, followed by Klebsiella, and both India and world, Listeria is also a common pathogen, right? Not the most common, but among top 4 or 5 causes. In case of age group of 2 months to 3 years, earlier it used to be H. influenzae. Now it is Streptococcus pneumoniae followed by H. influenzae. Then 3 years to 12 years. Earlier it used to be Neisseria meningitis. Some of the microbiology textbooks still talk about it. They haven't updated yet. But all guidelines, our books are clear now. The pediatric books are clear. It is Streptococcus pneumoniae followed by Neisseria meningitidis. And above 12 years of age, undisputed king in neonatal meningitis is always Streptococcus pneumoniae. So this is the updated list, and based upon what has been asked, you would be answering. So this was the age group which was asked. So whatever option would be there, the best possible answer you will be marking, right? So answer will be group B Streptococcus or Streptococcus agalactiae if it is mentioned. Question number 21. Which of the following is most commonly seen associated with carditis in a child with acute rheumatic fever? Rheumatic fever has 5 major criteria, 5 cardinal manifestation. Carditis, that is heart involvement. Arthritis, that is joints swelling and pain. Subcutaneous nodules, which are painless nodules on the extensor surface. Chorea, which is involuntary movement, usually delayed. And rash in the form of a skin lesion in the form of erythema marginatum. So it is found that all patients of carditis, they also have subcutaneous nodule present and vice versa. This is how these subcutaneous nodules look like. They occur on the extensor surface. So occur on the back of the elbow, back of the head subtypes. They occur on the back also, lumbar region. They occur on the tibia also. So extensor aspects it will be happening. These subcutaneous nodules are painless and they are strongly associated with underlying carditis. Older times में पुराने टाइम में क्या था कि ECG was not available at most places. So any child who would have subcutaneous nodule in rheumatic fever, we will assume that we don't need to check for prolonged PR interval or ECG thing. The child is having for sure some cardiac involvement even if the features are not present, even if it is asymptomatic. तो इसके लिए पुराना नाम था subcutaneous nodules were earlier known as poor man's ECG. What is poor man's ECG? गरीब आदमी का ECG. What it basically means is that if ECG is not available, presence of subcutaneous nodule indicates cardiac involvement in the patient. Understood? So answer here is subcutaneous nodule, strongly associated with carditis in the patient. 21 questions. Did pediatrics actually had 21 questions? Usually the number of questions of pediatrics is constant in FMG exam. It varies between 15 to 18. This time also the same was there. I have discussed a bit more questions because I wanted to cover as much area as possible, and there will always be some overlap topics. If you have read and prepared pediatrics conceptually and you have gone through all the major topics of FMG frequently asked in details and practiced MCQs, you would be able to get at least 19 questions correct out of these 21. 19 out of 21 is a excellent figure. With a bit of risk taking, a bit of MCQ solving, you could have got up to 20 also. So if you see, there are always solvable questions. There will always be unsolvable question. Focus on what is solvable and focus on concepts. At the same time, as exams come, change gears, go on to multiple revisions, fast revisions, and do not neglect the previous year questions. One-liners are important, but close to the exam, not when the initial 5-6 months are left before the exam. That is the only message I can say. So based upon if recalls change, the answers will also be liable to change. I hope you benefit out of it. Please add the points I discussed, especially related to HIV and especially related to TB meningitis and the various types of meningitis. Add them to your notes. Thank you very much.